Before I go on, I'd just like to introduce myself. My name is Inzaman Rashid. I'm a correspondent for Sky News, and I've been covering the coronavirus outbreak right from the offset. 5 weeks or so ago, when we first got a bit of a sniff that this was really affecting people like me more than the population suggests, I began to dig, and I've covered this story ever since then. Every other day I've spoken to families who've lost loved ones, whether it's sons and daughters of doctors, whether it's husbands and wives of nurses, brothers and sisters of bus drivers. And to me, anecdotally, the issue has been prevalent for quite a while now. And slowly that research and data has proved that. I think on behalf of all of us who are broadcasting today on the panel, which I'll shortly introduce, our hearts go out to everyone who has lost loved ones from whatever community, from whatever background, to COVID-19. Just on the data, some of the latest research from NHS England shows the deaths in hospitals. 19% of them are from a Black, Asian and minority ethnic background with COVID-19. That's 4% higher than the population. That's a clear indication that there is a disproportionate issue here. As of this morning, Sky News analysis has found that 64% of the healthcare workers that have sadly died with COVID-19 are from a BAME background. 64%. I'll just remind you of that number. And when we saw those faces at the start of this webinar, and when we see those faces every single day, whether it's on news channels, whether it's online, or whether someone else has tweeted a picture of someone who sadly passed away, we can clearly see that there are people from a BAME background. When we look at the workforce in the NHS, 21% is from a BAME background. And just a reminder, 64% of those who have died in the healthcare setting from coronavirus are from a BAME background. Some new data which will be published tomorrow by the ONS will reveal further information. I've been speaking to the statistician who's been working on this. I spoke to him earlier this morning, and he told me that the figures that will be out tomorrow, which don't include just deaths in hospitals, but in the community too, for the first time, by the way, will show a clear issue of disproportionality within BAME people. They're the facts. We can't argue with that. And we need to know why this is happening, what needs to be done about it. And to discuss this, we've actually got a stellar panel for all of you people who've tuned in today, to hear from you and later to answer some of your questions as well. So I'll introduce them all, and you can all give a bit of a wave when I give your name, if that's okay. So we have Dame Donna, the Chief Exec of Royal College of Nursing. Good afternoon. Dr. Joan Nagpaul, Council Chair of British Medical Association. Hello, nice artwork, Joan, thank you. Dr. Joan Myers, the Council Member for the Royal College of Nursing. Hello. Professor Shafi Ahmed, Consultant Surgeon and NHS Assembly Member. Good afternoon. We have Dr. J.S. Bamrah, the Chair of the British Association of Physicians of Indian Origin. Thank you. Dr. Shera Chok, GP and co-founder of the Shuri network. Hi, Shera. And Sir Sam Everington, British Medical Association Council Member. Hi there, Sam. So after this webinar, we will collate some important points and put together a bit of a formal plan, a formal letter that will be sent directly to the top. It will be after hearing your voices, hearing your concerns, and hearing what should happen and what should take place going forward. That will be sent to people like Matt Hancock, the Health Secretary, other politicians across the nations of the United Kingdom, and Sir Simon Stevens from the NHS as well. Let's kick off by speaking to some of our panelists and getting a bit of an insight into exactly what the fears and the worries are of those who are working in the healthcare service. And we will broaden this out to the community as well. But with these medics and nurses and other healthcare professionals that we've got with us today, I think I'd like to start off with Donna, with yourself, and then Chand, I'll come to you. What are the worries and the fears that staff on the front line fighting during this pandemic have been telling you over the last few weeks?
Well, we don't know what causes this. We don't know if it's exposure, we don't know if it's biology, but we know it is tied up with structural in, the determinants, the wider determinants of health and the structural inequalities that we see. So if you think about every single every single nurse, healthcare worker, when they see those pictures on television, it is very stark that the people that are dying look like them. And so that in itself is fearful. But then when you also think that most of our members, most of our nurses origin are frontline workers. So they recognise that they are in the firing line in terms of delivering care to patients. So there's a huge amount of fear. And then, of course, the fear is fed by the fact that managers they'll often see structural differences about who is sent to COVID-19 wards or who isn't sent. And that might be because they are the only people available. But actually, in the mind of my members, it is more than that. So there are some real concerns, real fear, real issues. And I've got several examples of frontline workers saying, yes, I'm happy to do the job that I've been trained for, but I want to see equal treatment of all who are serving COVID-19 patients.
John, just coming to you, thanks for that, Donna. Coming to you in terms of what medics have been telling you, this is clearly an issue, as we know, that has affected BAME people across the board, and particularly in our healthcare and social care systems. But what are the worries and the fears that medics have been coming to you to talk about?
So the statistics for doctors has been harrowing. We've never heard of this before, where you had the first 10 deaths of doctors, all from a BAME background, and now with over 20 deaths, 94% all from a BAME background. So obviously, this is very worrying for the front line, of whom doctors of an ethnic minority background make up a large part of the care we provide. They're worried, of course, for themselves individually. They're humans, they've got families they're concerned about. They're worried about spreading infection to other patients. And at the heart of this, remember, this is a virus which is caught through transmission by being close to others. So the very nature of being a doctor or a nurse is you are exposed to people who are infected. And this leads into the whole issue of PPE, because we've also, of course, seen that there have been shortages. And within those shortages, there have been issues around pressures some doctors and nurses have had. And we did a survey the week before last, which showed that if you were a BAME doctor, you were 3 times as likely to report feeling under pressure to see a patient without adequate protection compared to a white doctor. And in fact, this in a way highlights issues that have been going on well before the COVID situation, cultural factors, again, that we uncovered in the BMA in a previous survey we did before COVID, that showed that doctors from a ethnic minority background were twice as likely not to feel confident about raising concerns in their workplace. So what we're really worried about is that we have this issue. We know that if you are properly protected, the chance of getting infected is less. We're worried about doctors maybe being exposed, the wrong doctors at high risk being exposed, but we're also worried that those who feel inadequately protected may not have the confidence or may not be able to speak out because they're afraid of recrimination, or they're afraid of challenging the system. And so what we must do now is 2 things. One, of course, mitigate the risk through proper risk profiling, protecting those at highest risk, and that's what we've called for from NHS England. And the second is we have to address the cultural factors that disadvantage certain groups of healthcare workers.
I think we'll go on to some of the cultural factors very shortly, but picking up on your first point there, Chand, I want to bring in Joan Myers, who's kindly joined us this afternoon as well. And Joan, from a nursing perspective and from colleagues that you've been speaking to, PPE is clearly an issue that has been right across the board throughout this whole pandemic, whether we've sufficiently got enough PPE, whether it's got to hospitals quick enough or other healthcare settings quick enough. What have been the PPE concerns for a lot of nurses on the front line during this pandemic? You're just on mute, Joan, so you might just want to flick that off. Thanks.
Thank you for inviting me to be on this panel. in speaking to many of the nurses on the front line and social care workers, the majority of them are telling me that they haven't received the appropriate PPE that is required. Some of them, agency staff, have been told that they should be bringing their own. And so they have to really fight really hard to get the PPE they need to work in the environment where it's needed. I personally think that all members of staff, regardless of where they're working, whether it's in A&E, whether it's in the community or in the critical care unit, should have all the appropriate PPE. And the way I look at it is, in the war, you don't have some people wearing some uniforms, some weaponry, and they're not having a different kind of weapon in another part of the same war that they're fighting in. If people in critical care units, that you don't hear of many of them dying. I think there might have been one person in a critical care unit or ITU that's actually died, unfortunately. But those on the front line in A&E and in community services, in patient-facing services, are looking after people with risk of COVID but not been proved positive yet. And so when they prove positive, it's a bit late by then to be asking people to be wearing PPE. So we all should be given the appropriate PPE needed at the very first point that it's needed.
Some conversations that I've had with doctors, nurses, and other people who've particularly been working in ICU settings across the country have said that when they've not been getting the correct PPE, it's down to them sometimes being worried about shouting up and wanting to get the right PPE because they feel that they're not in the position to do that. Does that come down to inequality within our National Health Service, which many people say has been around for quite some time? And obviously PPE is a short-term issue that we can address. Do you feel that now that's something that can be addressed straight away? I guess both Joan and Donna can answer that.
Well, from my
sorry, Donna.
Yeah, from my perspective, it can be addressed. I mean, every single life is precious, and we've known that this pandemic has been coming. We saw it hit, China. We saw it hit other areas, and we can address it with personal protective equipment. It is something that we can do, and we just need, I suspect, a higher standard for all, because every single life is precious. So we're not saying, but clearly what we are seeing is that it's right for us ethically to focus on areas where there's evidence of the greatest harm. And we're seeing in front of us the greatest harm happening to BAME nurses and doctors.
NHS England have now said that BAME people are at greater risk, and that trusts across the country should be risk assessing their staff. Now, one would assume that BAME people right across the country are at greater risk for whatever the factors are. That's something that hopefully a Public Health England review will reveal in weeks to come, all these ONS figures that are being published tomorrow in weeks to come. Shafi, I'd like to bring yourself in and JS Bamrah as well. A bit about the risk to BAME staff in our healthcare system and wider BAME population. What do you feel are some of the risks, and exactly what needs to be tackled in the immediacy, I guess, to reduce those risks?
Thanks, Inzi. Thanks for asking to join this illustrious panel. I'll share my thoughts with you. The first thing to say, of course, is that there's been a lack of clarity for a long period of time. Now, that's the first most important thing. We've not had leadership in this area from NHS England and other parts, including chief executive of hospitals, giving us kind of a journey and a path and a timeline of how to manage this. So the first thing that people want out there, and the emails I've been getting sent over the last few days, is around clarity. What do we do as BAME community? If you're at higher risk, you've been, and now we're seeing risk stratification coming in from various sources. We've seen Somerset hospitals and I think Lancaster issuing some guidance around this. That's been missing so far. What we want is an adult conversation, with our clinical leads, or in fact, the chief executive directors, say, look, this is my risk score. Talk to me gently and maturely. How can you redeploy me? where are my risks, and allay my fears. So one thing that's missing is the guidance, the clarity of stratification, and secondly, the support structure. A lot of people are worried and scared. We've got over 750 people joining this webinar today. I had thousands more who want to join because they are concerned. That means there's been lack of communication, lack of clarity, lack of support, both in the primary and secondary care and also in social care. So I think those issues need to come across. Hopefully from this seminar, this webinar, one thing that will come through is that there'll be a top-down leadership. People say, actually, this is a problem. We're now actually facing it and challenging it and saying, okay, how do we manage this? We know there'll be a workforce issue. People may not decide to work in the front line, have to be redeployed. Those are serious issues and concerns we have, but we need to have adult conversation so that people feel supported and safe in this environment. That's kind of my opening piece. I think those are the essential parts of this conversation.
JS, just coming to you on the whole risk assessment issue. Just before we started this webinar, you said, okay, I'm not here just as a doctor. You're here as essentially a person from a BAME background and someone who's incredibly worried and worries about this issue. How important do you think a risk assessment is, not only in the healthcare profession, but when we get back to some form of new normal? Is that something that needs to be picked up by other companies and larger businesses?
Oh, thank you very much, Inzi. I'm delighted to be here with the panel, and hello to everybody. Well, look, a risk assessment tool is only as good as the person who's applying it, and also as good as the interpretation that comes out of it. And this, any risk assessment tool we do, we obviously have to do one now. It's only as, it's not going to last very long, to be truthful. We know that there has been a systemic problem. I've recently peer-reviewed an article for a major medical journal which asked the question, is this coronavirus a racist virus? Well, it isn't. There has been a systemic issue that the BMA, the Royal College of Nurses, even RES, and you remember Roger Klein's work, the pioneering work by Sam Everington and Anise Ismail, and the work that we've done in BAPIO to say that there is a systemic issue. What this has done is just simply expose that issue. We've known all about these risks. What we've got to do is not deal, the panic makes me think that everybody wants to address it just now, and tomorrow when the virus is gone, it's all gone, whoosh, like a magic lamp, it's gone. But actually, it's a little bit more than the risk assessment, if you ask me, Inzi.
What will these risk assessments, what kind of framework has been sent out for these risk assessments to take place? Because obviously, as NHS England have said, that BAME people within our healthcare setting are at greater risk. Sam Everington, I think you could maybe come in on this as well. Has there been any guidelines? Has there been any framework been sent out to trusts in order for them to go about carrying out these risk assessments? And if not, what should be in there?
Now, I've not seen any clear framework. So the general practices in our area have contacted, by the way, we risk assessed everybody, every member of staff right at the beginning, as we did actually review all the designated high-risk patients. Your difficulty here is this isn't the highest risk anymore, and it makes it really difficult to assess. There isn't clear guidance about it, but what's really important is to have those conversations with individual staff who have concerns. And you might want to indicate to them actually where there might be an area of concern. So the sort of things, but there again, it needs to be handled very sensitively because this is very confidential with a lot of members of staff. So there's something about the sensitivity of it. And as I say, we've sent a note out to all our staff saying, please contact us individually again, as we did before, and have a conversation if you want a conversation. But these are the sorts of things you need to be thinking about in terms of risk. Obviously, diabetes, heart disease, kidney disease, higher in some of the BAME groups, issues around multi-generational households, issues around obesity, so you're 40% more likely to die if you are obese. Socioeconomic factors, and this is really stark. So if you are rich, you're half as likely to die than if you're poor. And this goes to what JS was saying about systemic issues around discrimination in our society. And then, of course, issues around vitamin D. So we don't know whether it's connected or not, but what we do know is with a lot of BAME groups, actually vitamin D deficiency is a key issue. So it is incredibly complex, and there's a whole raft of people doing research, offering to do research. That's fantastic. That will help us risk stratify. But in the meantime, it's really, really important to offer conversations with all your staff and go into discussions about these sorts of areas. But also the discussion needs to be, as other people have highlighted already, about PPE, ensuring they have the correct PPE, whatever task they're performing, and that they feel safe in turn. So one of the things we started, 2 months ago with all our practices was to have huddles every 4 hours, keeping your 2 meter distance, but actually just to talk about what we were finding, what we were discovering, what were our fears. It's those sorts of things which are really, really important. It's about being open, having an open discussion, and making sure that staff really feel able to have those confidential discussions with their teams.
I'll bring you in a sec, Shera. Just a reminder to those who may have tuned in late. Thanks for everyone who's sending in questions on the side. We will get to questions very, very shortly. We've got a brilliant panel here who will be able to answer some of them soon. We're discussing the issue of disproportionality within BAME deaths, not only in a healthcare setting, but in the community as well. And by the end of this webinar, we will hope to put together just afterwards a bit of a plan, a letter that will be sent right to the very top, including Matt Hancock, Sir Simon Stevens, other politicians and medics as well. Shera, I'd like to bring you in on the back of Sam's comments there about PPE and risk assessments.
Absolutely. I wanted to talk about accountability and leadership, because one day when this is over, we're all going to have to ask ourselves and look in the mirror and say, well, what did I do about what's going on and the discrimination? Because once you know what's going on, and we all know what's happening with the information and the data, that makes us responsible. And we can't outsource what's happening around BME populations. This is something that needs to be owned by every chief executive, every board member, every trust, every commissioning group, and every organisation in the NHS and care. We cannot say this is something that the HR team will do or the BME network will sort out. This is something every chief operating officer, every finance director, if we really truly care about patient safety, this is not just a nice soft fluffy thing that we should do in terms of the risk assessments and the PPE. It's absolutely critical. It's a medical emergency. And we know that as leaders, our job is to make sure that our staff are enabled to do their jobs well. And therefore, we need to take those actions that we've outlined immediately.
And how much, sorry, Shera, just to jump in, how much does the panel feel, and I guess you guys who've tuned in to listen to this as well, how much do you feel that inequality within the healthcare system and in the community has played a role in this disproportionate number of deaths within the BAME community? Donna, I'd really like to get your thoughts on this, if possible. We've seen the RES data, the workforce race inequality standards data over the last 4 years within the NHS. Year on year, we have seen increased harassment and bullying towards BAME staff within the NHS from their counterparts. Donna, what's your, I guess, reaction to that, and whether that plays a role in this pandemic?
Well, certainly what I'm hearing from nurses that have written into me is that they feel that if they raise it as an issue, then they are victimised or ignored. So actually, I just want to point out to everyone that it is the job of an employer to protect their staff, whether it's from a virus, whether if this was a factory. Now, the health and safety executive have said that everybody, people should be risk assessed. That's the law. So I'm not sure where we're getting off moving away from that. And it should be individual risk assessments. So there is no point in us sitting here saying, well, employers can move away from that. They have a duty of care to their employees. It's not unusual. And therefore, it smacks of the obvious to me that if you see individuals that are dying, you know, at a greater percentage, then you need to look and understand. But you take steps to alleviate it. It'll be all fine if we wait until this is over. But we can't afford that because people are dying in the moment. And I would just say, in the 200th year of Florence Nightingale, if she was to sit and wait without using her skills of observation, where would medicine be? She went against the prevailing thoughts that were happening at the time, and created her own science, if you like, through looking at what was happening. And I think for me, what I'm seeing as my members, as nurses, as healthcare assistants are seeing, that there is, whether it's structural inequality or not, we need some protection here, fellas.
John, bring you in there. Thanks for that, Donna. You're just on mute, John.
I just want to say that although I'm speaking as a doctor, we mustn't forget we are part of a community of health and care workers. It's not just doctors and nurses. My heart goes out to care home staff, the carers who actually have to visit patients, some of whom are known to be infected, others we don't know about. They don't have proper protection. And in fact, we need to get this right for the entire community of staff who are caring for patients. And we mustn't in any way start to divide ourselves up into one being more important than the other, which concerned me at the beginning when there was a lot of talk about protection being there for the NHS, ignoring the fact that care home staff also needed protection. So we need to really be together as a community of staff in addressing this.
Inequality is clearly an issue, and the data suggests that, Shera, as you pointed out. Do you think this pandemic has maybe brought this to the attention of people who can potentially make change? And do you feel that in the long term, this is now something that needs to happen, so that if, you know, God forbid, another pandemic like this comes around, we aren't in this position? Does anyone, I'll put it out there for anyone to answer, really?
I think in the here and now, I'm very clear that given that we couldn't operationally manage the NHS without the BAME community, they need us more than we need them. And actually, it's our time to demand that something is done about this. I'm really tired of hearing, you know, it's not the same for, we need to treat every community equally. I mean, I recognise that every single life is precious, and it's not just the BAME community. But when I speak on behalf of my members that are delivering community services in care homes. Everywhere you'll find nurses. So I'm speaking on behalf of those that have had to go into homes without PPE when they know that there are COVID-19 patients there. So I'm speaking on behalf of, and it is our opportunity to actually, you know, let's talk about race now, and let's talk about ethnicity, because it is our opportunity to raise it, because we can see with our very own eyes that we're being unduly affected.
Donna, I think that's incredibly powerful. It's just a shame that it's come to thousands of deaths within the BAME community, I guess, for that conversation to come about. I'll go to JS first, if that's okay, and then Joan, I'll come to you. JS, if you don't mind picking up on that point. And Donna, just to tell you as well, a lot of people commenting after that comment from you, people thanking you for speaking out and saying that for quite an important point.
And absolutely, I think Donna's echoed everybody's sentiments, because no more of this. For every death of the 30,000 odd people, you know, there's a whole tragedy, there's a family behind it. For every death of the 200 plus healthcare workers who've dedicated, many of them BAME, who've come from overseas, who've left their lands where they were born, come here to help us in the National Health Service, where some of us are immigrants. We've come here because of the pride that we take in working in the National Health Service. And the National Health Service it's not the National Health Service that has let us down. People feel very angry about the National Health Service. It's the best institute in the world. It's the people, our leaders, who have let us down. I have so many harrowing tales, Inzi, as I'm sure you have had, of colleagues on ventilators looking after their own colleagues in ITU. I mean, it's harrowing. It's absolutely heartbreaking when you have to look after your own colleagues, some of whom will die. And I think we should actually declare today that every death of a healthcare worker from COVID is a never event. It will never happen again. And in the event that it does, the greatest powers will come down to actually look at every such incident. Every death of a healthcare worker from COVID should be absolutely a never event.
Shafi, I'll bring yourself in if you don't mind, and Joan, then I'll come to you afterwards if that's okay. Shafi, your response to that?
I totally agree. I think that Donna was very powerful. Thank you for Donna for raising that concern for all of us. Jess is right. There should be an every event. More importantly, I think it highlights two things. One is inequality of health, which is a bigger determinant. And second is about leadership. We've been failed by leadership here. If you think about where we were 20 years ago and now where we are, we're no different. The hierarchy of the NHS, sadly, is still run by white middle-class people, generally, right? You look at all the chief executives, the boards, etc. So how are we facing that challenge? This just undermines, it kind of exemplifies where we've been for 20 years. Where the promise has been there, I think that lack of leadership, and now what's happening, lack of communication, because not understanding the problems that we're facing on the front line and not addressing it. So those are the key issues from a kind of a higher level, Inzi, that I think hopefully this COVID-19 gives opportunity to redefine that process for all of us.
I think this is clearly a key issue, which will have to eventually become in one of the points sent across to the top. Joan, I'm going to come to you quickly, then to Shera afterwards, and then we're going to move on to talking a bit about data collection and how of an important role that is. So we'll bring in Sir Sam Everington into that very shortly. But over to you, Joan.
I agree totally with what Donna said, and basically what Dr. Bamrah said. It should be a never event. And when I see on Twitter every single day, we see the numbers going up, particularly we can see very starkly of the Filipino community. Each death should be actually examined, should be investigated with root cause analysis, so that by now we should be able to say these are the reasons why they're dying, and this is the things we're going to put in place to mitigate it happening. And as mentioned before, many BME people haven't got the confidence to speak up. And when you're working in a care home where your job is attached to a work permit, and if your manager requests or commands you to do something and you know that you're not safe, but if you say no, there's a possibility they will remove your work permit and you have to go back home, then they've got a dilemma there because they have to feed their family as well. So we need to really take all these structural inequalities, this discrimination that's going on so blatantly. I hear of BME people being asked to go to the COVID positive wards. Many of the agency nurses or bank nurses are from a BME background, and they're being sent directly to a COVID positive ward, and some of them do not have the appropriate PPE. It's just blatant. You couldn't get it more blatant than that, especially when you see their white counterpart is not asked to go to the COVID positive ward, or in one instance, when they complained about being on the COVID positive ward, they'll move back to where the unit they were on before. Yet the black colleague that actually asked specifically, I can't cope, it's too stressful, I want to go back, they're told, sorry, you can't go back. And this particular person became COVID positive. And then the manager said, don't worry, take your time off, and when you come back, we'll make sure that we'll send you back to your unit before. Why couldn't they be treated equally?
It's a powerful point.
It's so blatant. It's really blatant.
It's a really powerful point, Joan, and thanks for pointing that particular case out, even though it is an incredibly sad story. Shera, I'll come to you in a sec, but I think we should probably point out the obvious here. We have got one of your white counterparts on the panel, and Sir Sam Everington, I think it'll be important for us to ask you from your perspective, as you know, looking at this panel and your colleagues, so many who are part of the NHS and in social care settings as well. What is your reaction to the whole inequality, to the race issue, and to the fact that this is clearly now playing a part within this whole COVID-19 pandemic? You're on mute, Sam, sorry.
The first thing to say is this has sadly been going on for years. So many of you will know of Professor Anish Ismail and my research, which we published over the years. Probably the one that is best known is when we sent fake applications to junior doctors' jobs. The only difference in the application was a traditional Indian surname or traditional English surname, and you were half as likely to get an offer for a job. And we then looked at every stage of a career, of the career of a doctor in the health service, and we found discrimination. You know, 3 times less likely to get a clinical excellence award. Wherever you look, there was a problem. The sad thing is very little has changed. And Donna makes entirely the right point. There is a moment now where this absolutely has to be addressed. The second issue, and people have raised it on the chat, is this issue of Roger Klein's Snowy Peaks. Well, in 2012, the government got rid of the Appointments Commission. This was an amazing organisation that was actually addressing the Snowy Peaks, and we saw great advances actually in the top tier leadership in the NHS. It was far more diverse, and it went backwards the moment the Appointment Commission was ended. So there's something about actually really holding the system to account now and saying, this must stop, this must change, and let's go back on a regular basis and look at some of the data, look at some of the research to show whether it's actually changing. And I suppose my final point is that actually what we've got to do is share the data on all this information, so that actually what's really important in East London, for example, we share anonymously 2 million database of primary care notes, which enables us very quickly to answer questions about what's the granularity of some of this inequality. So that actually when you can have a conversation with an individual patient, actually it's far more detailed. It's not just actually, yes, you are more likely to get ill because you are from a BME group, but actually dig down into what are the factors that need to change to bring back that risk to normal. And that's why collecting the data overall and sharing that data is absolutely vital. It's why I raise those issues of differential inequalities in health. That's why it's so important, because actually that enables people individually to deal with it, but also the system. So the big system questions is, well, why isn't vitamin D actually provided in school to children? Why isn't there much more investment in diabetic care? These things are both individual and system things and need to change across the whole system. And I have to say, finally, I'm so fed up with going round and round in circles over this for the last 15 years. Now we have an opportunity to give really clear advice to leadership, to government, about what needs to change now.
We'll come on to data very shortly, so thanks for that, Sam. Really appreciate it. Dr. Shera, Chok, I just want to come to you with something that you had to chip in with.
Yeah, I want to pick up on what Shafi said about comms and engagement. The NHS is incredible. When we want to do something quickly, like build a hospital, we can do that in 10 days. But I want us to think about how much communication engagement there really has with different communities, including the BME community, but others as well. And 6 or 7 weeks on, I'm still struggling to see how much true engagement has there been with groups that have been perhaps a bit more challenging to reach for all sorts of reasons like language and culture. And what evaluation has there been of the initiatives that have been out there? Now, we keep talking about new normal, and I'm really tired about hearing about the new normal. And any conversation about the new normal that does not address reducing health inequalities and discrimination just isn't worth having. And the last point I want to make around communication, as an example, and I'll bring on technology, the contact tracing app. Now, if this is going to work, we need good uptake across everyone, particularly the high-risk groups. And we already know that BME groups at higher risk. So why are we not piloting this in areas of high risk of mortality like Brent, Newham, Hackney, and Tower Hamlets? How are we engaging community group, the third sector, religious leaders, and people on the ground to develop and roll out the contact tracing app?
That's an incredibly important point, Shera. Thank you. How many BAME people live in the Isle of Wight? I mean, I don't think I can answer that question. I'm sure not many. Thanks for that, Shera. I just want to move on to a point which I found quite striking throughout covering this pandemic from a journalistic perspective. Data is obviously hugely important. Stats is hugely important, and usually from data and stats you can find out answers as to why something is happening. And I was incredibly shocked when this whole issue came about, that the data that is being released only shows the ethnicities of those who have died within our hospitals. I can't see how many people from a BAME background have died with COVID-19 in our communities. I can't see how many people from a BAME background have died in Wales, in Scotland, in Northern Ireland. When someone goes to register a death in the community on the death certificate, there is no ethnicity. Now, someone please correct me if I'm wrong, but a couple of weeks ago, Professor Chris Whitty and the other medical officers of the other nations said that this is such a simple thing that they can do and that it should be done. And they've got no idea why up until now it's not being done. How much of an important role is data for us to identify exactly what the issues are and for us to make changes right now, immediately, and for the future? Is there anyone there that wants to comment on that? Chand, I'll go to you first. You're on mute, Chand.
Data is so important. I haven't got confidence that at the moment that we've been told about how this review is going to get the right data. We shouldn't just be looking at death as the only barometer. We need to know about the ethnicity of people who are admitted to hospital. We need to know their occupation. We need to know if they were a health or care worker, whether they were exposed in a particular environment. We need to know what their own experience of protection was. And so rather than make the death in every event, we need to go much earlier into that data. It's not being collected. The community information is woefully lacking. I'm in a part of North London which has a 30% Asian population. We're getting death notifications quite regularly every single day. We don't have that data is not collected because they're community deaths. They've not been tested, so they won't figure in the national statistics. And there's another inequality in terms of COVID, which we're not perhaps talking about, which is the impact on all the patients who have non-COVID conditions, but very serious conditions. They're not, we've seen a 50% drop in people with heart attacks attending A&E. I've seen lots of my own patients who are not seeking help because they're not getting it because they're either shielded, they're not getting the right home services, and they're suffering in silence. So I think there's an inequality both for COVID, but the other medical conditions, the renal conditions, people with uncontrolled diabetes, etc. Those services aren't there. We need data for both groups, COVID and non-COVID.
Thank you, John. Shafi, I'll bring you in. What I just don't get is that we can clearly see the roles that some people are doing. We know whether someone is a key worker. We know whether someone has got underlying health conditions. But when these people have sadly passed away with COVID-19, we haven't been able to link those things up until now. And surely that information would give us the answers as to why this disproportionate effect is happening.
So going back to what Chan said, I totally agree, data is absolutely crucial in all of this. And actually one of the things that COVID-19 has highlighted is the lack of data that's out there, or in terms of Public Health England, etc. So actually we've not been collecting this, or if it has, it's not been visible. So that's one thing that's highlighted, maybe will be better the next pandemic, let's hope so. But we do have data though. Look, you've just mentioned that at the outset of this conversation, the seminar, that 64% of BAME were dying of this disease at the front line. That's data, right? So the question is, if you do have that powerful data, why not working towards it? We knew that 3 weeks ago, actually, in Z. Why take so long for that more data that we have to emanate into some kind of action? That's kind of a real problem, the inertia. You've got some data, we're all concerned about it. We've got 800 people here on the webinar. Where's the change? Where's the management of that problem? Where's the understanding the anxiety and creating something that we can sustain ourselves with? So I think we do have some data we can work with. I agree, Sam, more research will be required going forward. But today, here and now, we have a duty, a moral duty, to ensure that we keep people safe front line is by dealing with this here and now. So that's kind of my imperative from this webinar.
Thanks for that, Shafi. JS, I'll give a quick comment from you, and then hopefully we can get to some questions, because they've been flying in on my comments section to the right of my screen here, because the conversation has been so interesting and one that needs to be had. So JS, I'll go to you for a quick point, and then we'll get to some questions.
So, I was going to say that, as Chan said, data is obviously very, very important. Science is very important. The interpretation of both within this COVID crisis has been flawed, I think, right from the start. We wrote to NHS England when the first 10 BAME doctors died, and it took 3 weeks for them to respond. You know, sometimes the data is staring in your face, but you're so biased. I don't like this term, unconscious bias. Let's just call it bias, you know, let's ditch the word unconscious. And I think then we would get somewhere, because I think people do feel this is an appetite for change. One of the other things, if I may say this, put in a plug for mental health, if I may, Inzi, I'd be doing a whole lot of disservice to all those mental health patients and our mental health practitioners, because we've in all of this, we haven't tackled what's going to come. There's going to be an epidemic of mental health problems after this, as Andy Bell has said to us on our chat line, because that is the real disparity, the inequality. And there have been social determinants that Michael Marmot has been talking about for ages. We really need to do something about it. So data, yes. Science, yes. Can we get real people interpreting it? People who are clinicians and not bureaucrats sitting behind desks who just dish out policies without knowing patients and people?
Thank you for that, JS. And I think that's a question that probably a lot of the panel have been asking for some time now, and one that we all want answers to. Look, just remarks from me before I go on to some questions. Every single day of this pandemic, I've spoken to family members, whether it's someone from the white community, whether it's someone from a Black, Asian, a minority ethnic background who has lost someone to COVID-19. Just a couple of days ago, I spoke to a woman who lost her brother, her father, and her uncle, all in the space of a week. They were from a Sudanese background. And people are furious. People are angry. People are incredibly upset, as you'd expect, but they are angry that this has managed to happen. And clearly, questions need to be asked and answers need to be heard. And what I hope is that after this webinar, when something is sent from the panel directly to the top, that answers will be heard and direct action will be taken. Let's just move on to some of the questions. This one's from Dr. Liana Lopez. She's an educational psychologist. And Dame Donna, I think this would be one for you to answer if possible. Dr. Lopez says that she's interested to know how we can support both BAME employees and key workers to feel confident in their employers taking seriously their potential risks in returning to work.
So I think it's important, it's certainly at the Royal College of Nursing, what we've been doing is providing our members with the questions that they need to ask for a risk assessment, and being very, very clear that actually if they're put into situations that mean that they feel both physically or psychologically unsafe, then they have a right to step back from that. So we've been very, very clear with our members, and we will support them, rehearse with them, and we will take the issues on for them. And that's whether it's a healthcare assistant or, you know, somebody working in ITU. I think we've got to be very, very clear that there is a choice. We choose to nurse. We're not soldiers. We didn't sign up for war. We understand that if this is an occupational hazard that happens in our occupation, and we're very, very happy to step up and serve, but give us the right equipment so that we're able to do that. And I'm very, very clear about that. Please don't clap for me, save my life.
Yeah, I like that.
Anyone else would like to add or respond to that question? Chand, yeah, please. You're on mute, sorry, Chand.
The question included key workers, and let's not forget that the nation has been kept functioning because of staff who have driven buses on behalf of others, who have kept supermarkets functioning, cashiers who've been seeing hundreds of people every day with no protection, taking payment 2 or 3 feet away. Shopkeepers who've kept other, you know, we all of us in London will just know how the BAME community is full of key workers in that regard. And they haven't had protection. And I think it's really important now that anyone who's providing a service who cannot socially distance, they're not at home in a lockdown, they're actually out there serving the community. They are frontline in their own way, and they need to be protected in their work and gratitude paid for what their part they're playing, in addition to all of us in the health and care sectors.
Thanks for that, John. We'll move on to another question now. This is from Saeed Ahmed. Testing of all key workers is an important part of government strategy. So do we have any data so far as to how many BAME colleagues and their families have been tested as a priority? Obviously, this comes down to data again. And are we seeing less BAME colleagues being tested, or are we quite equal on that? Open to the panel. Yeah, JS.
So I think, Inzi, the rollout on this, you mean testing as in not risk assessing, but test. I don't think we've got the data yet.
I think this is testing, yes.
Yes, I don't think we've got the data on testing at the moment, on how many people have been tested that are BAME and non-BAME. So I think we'll have to wait for that to come out. If you go by the evidence we have from PPEs, I think you would expect a disparity. I would expect a disparity. And I think people out there, I think you've got to just be aware, look, if we need tests, we need tests. I think tests are now on a bigger scale. I think the point that Donna and Joan make are very appropriate. And John's made comments about key workers and all there are more than doctors and nurses at the front line. And I think what Donna said rings true to me. And I'm going to admit this to all of you. I found it very difficult to go out on Thursday and clap. I couldn't last week. There were people I knew who were on ventilators, people who have died, you know, who we know of, health colleagues. It's very difficult to go out and clap, I'm sorry to say. There has to be action, like now. And testing, but vaccinations will come out as well. I don't know how effective they're going to be in the short term, but they will be effective. And we have to make sure that, you know, healthcare workers do not feel discriminated when it comes to testing or vaccinations.
The Public Health England review, which was announced, I think, 3 weeks ago now, is currently taking place to find out why this is such an issue. It was only day before yesterday, I think, they released more details of what the review will actually entail. A question from Donald Palmer. In the government inquiry into disproportionate impact of the coronavirus on the BAME community, how can we ensure that voices from the BAME communities will be heard? We know there's been some controversy about who is potentially on that review panel, essentially. How will we ensure that voices from the correct BAME communities are heard? Joan, I think you could probably come in here.
I think it's really important that we hear the lived experience of those that have actually gone through the pain of COVID and survived, and those that are living with grieving the loss of their loved ones. They're the ones that we need to be hearing on the panels. It's no point having all these experts and all these analysts and scientists and bureaucrats and everything. We need to have real people, real voices, and hear what they have to say so we can come up with some kind of real conclusion of what needs to be done. Because it's the people on the ground that knows what needs to be done, because they're the ones that are suffering. But I think for too often, we keep reeling out all these great names, great titles, and then nobody has any confidence in them anyway. But if you have some real people that have gone through the real issues that we're talking about, then people will be more confident about the results we'll get at the end of the day.
Anyone else want to throw in that? Shafi, please, yeah. Yeah,
I think one thing that's highlighted that, of course, is the disconnect between various organizations. Like here we have an amazing array of talent. None of these have been asked to comment on this research and etc. Why not, for example? Why not get that community together? Because it is our community, after all, we know most about them, to help support. And you wonder how they go about these kind of exercises. And also you said it's 3 weeks now, right? As Shera said earlier, it took 14 days. I was part of Nottingham Hospital to build a hospital up and running at the Exeter Centre. 14 days, so 3 weeks to get no information from review that's affecting us every day of our lives and people down the front line. So it's slow, it's cumbersome, not good enough in my perspective. The way they've arranged the people that run it also, I think, leaves a lot to be desired. I think we need to connect with it. There's lots of seminars, webinars going on, a lot of connected people talking about this whole issue. And I think that the structure is, how do we get that community together to have a common voice? Yeah. so that we understand where we are, we have a rationale behind it, and we have a timeline that's sensible and deliberate. So those issues that I think we've almost, we need to overcome some of those barriers to ensuring that we do this as quick as possible.
Anyone else want to quickly add to that before we move on to another question? Nope, I think we're good. This is from Rob Neal. I think our best response to this pandemic will come down to empathy, equality, and political will. There needs to be a sustained redistribution of wealth and other resources, housing and secure jobs, if we ever are going to address the underlying causes of these disparities. This probably comes down to social inequality, not necessarily just in our healthcare settings, but socially as well. How important do you think it is that the government should be looking at that in light of this pandemic? Joan.
Yeah, so I think what this has shown is that there are also differences within the different ethnic minorities in terms of death rates. As you know, the Black African death rate is about 3.7 times that of whites. The Pakistani is about 2.9 times. Bangladeshi is about 2 times. So there's differences, and those differences, I think, are a result of some ingrained inequalities. We know that 30% of Bangladeshis are in overcrowded housing compared to 2% of the white population. What a stark difference. And you can begin to see the reasons why this is playing out this way. We talk about key workers. Large numbers of Pakistanis are taxi drivers in London. They don't have protection. They're mixing with people in the confines of a car, which is probably air conditioned at times. And we've got to understand, I think, this has really brought to the fore the need to understand long-standing social inequalities, but those inequalities may also be very specific and different in different cultures. And we need to do this properly and address it in a proper way. And that's where the PHE review needs to give us confidence. We have heard very little detail after 3 weeks. We don't even know what data they'll be collecting. Yes, I agree with you.
Sam, I'll come to you if you don't mind, and then Shera will come up to you.
Yeah, so housing, of course, is vital in the East End of London, exactly Shan's point. But the other thing I wanted to raise also is education systems. That creates a massive, I see the inequalities grow from the age of 5 to 18. I'm a governor of a primary school, but it's very, very rare for a doctor or nurse to be on the governing body. And yet so many of these things start at this age. They're almost schools in some of the deprived areas like incubators for long-term conditions and inequalities. And we have to find some way of addressing that. So, for example, Donna's research shows that there's been a 30% drop in school nurses in the last 10 years. And yet the health of kids is getting worse. 40% will be obese or overweight by the age of 11 in the next 5 years. London and East London has already hit that target. So actually you need to start right down at the beginning and ensure that every 18-year-old comes out of school with exactly the same equal opportunity as everyone else. And there are very simple things that can be done to support that. Yes, it's about high education standards, but it's also about health. Health is absolutely critical to support people in the modern world, where, by the way, we're told that 40% of jobs will go with artificial intelligence. Well, who's going to be the biggest losers there, okay, in that artificial intelligence journey, which is almost unstoppable? So schools, absolutely important. In fact, what you need to do is almost look at people at every stage of their life, you know, starting from what I call -9 months to 5 years, and across people's whole life course, and say, what is it we need to do at every stage of people's life to address these inequalities?
Thank you for that, Sam. Important points there. And Shera, I'll come to you. We've got a couple of minutes just before this webinar is coming to a close. So Shera, I'll come to you for your response there.
So the Institute for Physical Studies published a report last week which showed that deprived communities and some BAME communities are going to take a double hit. So not only are these groups more at risk from dying from COVID, they are more at risk as well from losing their jobs and losing their income. So it's a double whammy for the people who are most vulnerable. And this comes back to accountability, and this needs to be mandated. So if you're a leader in the NHS or care sector, if you're a chief executive or an acute trust or a commissioner or a primary care organisation, this needs to be part of your job. It can't be something that is something nice or soft to do. NHS England and the government need to make every chief executive and every chair and every board member accountable for reducing health inequalities and discrimination.
Shera, thank you so much.
Sorry.
Yes, please, Joan. Yeah, come in.
I was going to say it's really important that on all the boards and panels and committees that they have, they need to have a diversity of thought and perspective on those panels. If they don't have that on the panel, then they're not even going to address the issue that we're talking about, or it's going to be addressed very superficially.
Is that something you find it isn't the issue right now? Are we finding that boards and panels and I guess chairs across the board, not only in the NHS but wider businesses and communities, we are seeing that lack of representation?
Definitely. And I'll give you an example. When they were doing the NICE guidelines, my speciality is eczema, management of eczema in children. When they were doing the NICE guidance for that, I was the only BME person or black person on the panel. It's very obvious that black skin is different to white skin, but nobody mentioned it until I brought it up and said black skin presents differently with eczema to white skin, and that's why it's being misdiagnosed. And as a result, they had to write it into the NICE guidelines. But if I wasn't there, they knew and they wouldn't have said it, although they know that already. And that's just one example.
Yeah, it's just one example, exactly, and probably extends to the wider argument and discussion, really. Look, we've had so many questions come in. I genuinely wish we had time to answer all of them. It's clearly a topic which people have got questions to ask and want to hear answers. And just like all of you as a panel, myself included as a journalist with Sky, I want to hear answers as well and to find out exactly not only the causes, because I think most of us can get to the conclusions of that, but what specifically will be done in the here and now and in the future to ensure something like this doesn't happen again. I think we'll follow up some of those questions. I'm sure we will in the future. And I think a discussion like this is incredibly important, not only because it highlights the issues, but it means that now we can put together the thoughts of the panels, the people who have been watching and listening as well, and send something directly to the top. And it's essentially putting more pressure on those who have the power to make a change and to make a difference. So again, to the panel, to JS Bamrah, to Dr. Shera Chok, to Dame Donna Kinnair, to Nagpaul, to Dr. Joan Myers, to Sam Everington, and to Shafi Ahmed, thank you so much for taking your time out to comment, to give your views. You're all incredibly esteemed people in this sector and obviously have very important views. And a big thanks to the hundreds of people who have tuned in to watch and sent your comments. I'm so sorry that we couldn't get all of them across to the panel, but I'm sure in the future, if we do some form of follow-up, we will be able to, and we'll keep everyone posted with some form of letter or point plan which is sent to the government and to the top of the NHS. For now, thank you. Keep fighting, keep raising the awareness, and again, we give all our thoughts and love to those who have sadly lost their lives to COVID-19, especially those in the Black, Asian, minority ethnic community. Thanks again all, and enjoy the rest of your afternoon.
Thank you.
Thank you.